quantitative gated spade. Left ventricular ejection fraction. The evaluation of ventricular arrhythmia was based on Holter electrocardiogram at the same time. We divided the 100 patients into 3 groups, depending on ventricular arrhythmia. 1, non or PVC, knee couplet. 2nd couplet. 3, non-sustained ventricular tachycardia, NSVT, or ventricular tachycardia, VT group. Extent score. The definition of extent score is shown in this slide. Short axis images of left ventricle were obtained after reconstruction. In each short axis image, ischemic regions were analyzed circumferential area. Hyperfusion less than 2,000 standard deviation from the mean was defined as an ischemic region, and each area was extent score. Extent score was automatically calculated by QPS software. The patient is a 24-year-old female. She had repeat MI. Extent score was 22%, and LVEF was 49%. NSVT was detected. In this slide, the relationship between the extent score and ventricular arrhythmia is shown. The vertical axis indicates the extent score, and horizontal axis indicates the interval from the onset of KD to MPI. Yellow circle crosses indicate no arrhythmia or single PVC. Blue square denote couplet and orange marker denote NSVT. As you can see, orange marker cluster in the right upper area. This table shows the clinical characteristics of each ventricular arrhythmia group. In the NSVT group, note the long interval from the onset of KD, the higher extent score, and low LVEF. Next slide shows the result of multivariate analysis. Extent score was the most significant marker for the prediction of NSVT. The cutoff value for extent score predicting NSVT was 11 points, and the interval from the onset of KD to MPI was 17 years. In summary, the factors related to the appearance of NSVT in patients with CAL caused by KD was the interval from the onset of KD and extent score. Case presentation. Here we see an adult patient in detail. A 34-year-old man visited hospital because of headache. An electrocardiogram revealed an abnormal Q wave in lead to poor progression in V1 and V2, and flat T waves in V5 and V6. Electron beam CT showed a calcified giant aneurysm. Coronary angiogram revealed segmental stenosis of RCA and occlusion of the LAD. He had had unknown fever at the age of 10 months. At the age of 43 years, he attended the hospital because of fever and palpitation with a common cold. An electrocardiogram revealed ventricular tachycardia. His MPI is shown. Asymptomatic interseptal and posterior inferior myocardial infarction was suspected. Extent score was 24%. LVEF was 39%. In treatment, coronary artery bypass grafting was done and an implantable defibrillator was inserted. Next, I talk relation between the rate gadolinium enhance and ventricular ejection fraction in CMR. LG indicates fibrosis of myocardium. Transmural extent of rate gadolinium enhancement, LGE, is shown by yellow area. The grade of LGE is based on transmural extent hyperenhancement. We analyze the relationship between the degree of LGE and ventricular fraction, and diastolic volume index, and systolic volume index, ejection fraction of the right and left ventricles. We divide it into 4 groups based on the trans extent of LGE. Grade 0 and group 0. Grade 1 is group 1. Grade 2 is group 2. Grade 3 and grade 4 is included in group 3. This slide shows grade 1, a 33-year-old female had CABG in 19 years old. This slide shows grade 4, an 80-year-old boy, and AMI and coronary artery bypass grafting at 8 years. This slide shows coronary angiogram. Her left LAD was occluded, but collateral arteries, RCA, from RCA to LAD. In this patient, transmural extent was grade 2. Patient population is shown. 65 patients included. The age at CMR ranged from 5 years and 47 years, with a median of 29 years. The interval from KD to CMR ranged from 3 months to 3 years to 43 years, with a median of 20 years. Occluded vessel 172 to 127 to 24, 3, 3. Previous myocardial infarction was found 17 patients. Coronary artery bypass grafting was found 36 patients. Results are shown. There was no significant in right ventricular function, but there was significantly difference in the left ventricular function. In 4 groups. Their results are shown. Previous MR was found in group 2 and 3. On the other hand, coronary artery bypass grafting was in all groups. There was a significant difference between LGE grade and LVEF. In summary, existence of LGE more than or equal to 5% in the myocardium suggests adverse remodeling of the left ventricle, although LGE was found in more than half of the study patients with LCAO, the transmural extent of LGE was less than 50% in most of them, and their global LV function was preserved. Global LV function in the patient with CARS by KD was usually preserved. And this paper is published. Grade of LGE enhancement in ACAO, asymptomatic coronary artery occlusion, and myocardial infarction group, showing a significant difference between groups. Grade of right gallium enhancement and left ventricular function. In MI group, left ventricular function was significantly decreased, but ACAO, in patient with ACAO, left ventricular ejection fraction and LVEDVI was not always decreased. In patient LV function in patient with ACAO is preserved. Thank you for attention.
Any questions, any comments?
I have just demonstrated the three comments, which I think maybe the take-home message that the infarction that occurs as a mark of due to the coronary artery problems, maybe stenosis, thrombosis are territorial. And the extent and graduality are rather than 2 years. The rule of the thumb is any infarction rather than 50% is vibrant. Anything which is more than 50% will not vibrant. And that's how the IVE models. And when the infarction is more than 50%, 50%. What I will be reversible is that Madam is putting on the slides that once you do CABQ also the functional recovery is not possible. So even if the 50% is the rule of thumb. Anything below 50%
Thank you. Yeah, thank you, thank you. Yeah.
Just wanted to ask, before any intervention, whether it is cath or surgery mainly, is there any way that we would know that this is a viable marker or this is a non-viable marker? Can we know the coronary?
Yeah. For indication coronary CVD, intervention. Yeah. Yeah. I do coronary flow reserve by transthoracic echocardiography. I use, but FFR, CFR in cardiac catheterization, the value, cutoff value, is not always appropriate for adult patient case. Uh, 2.0 cutoff point 2.0.
Into resting coronaries or after exercise?
Yeah, I don't do.
Thank you.
Any other comments? So, thank you, ma'am. Thank you again.
So we move ahead with the next session, that is the oral presentations. We have 8 oral presentations in line. So we look forward to the interesting cases and engaging discussion. For chairing this session, we have Professor Tapas Sabul and Dr. Saji Phillips. I would like to call upon our first speaker on the dais, Dr. Ananta Nandi, sorry.
Next is it?
Which is the light mark. Okay, this is next.
Next.
Good afternoon all, my respected teachers and judges.
Oh, sorry.
Privileged to present this case today in front of the learned audience. So my case is clinical profile of coronary artery. Sorry, sir. Okay, sir. Should I start, sir? Okay. My case is clinical profile of coronary artery aneurysm at diagnosis of Kawasaki disease, a retrospective observational study from a tertiary care center in eastern India. So as we all know, Kawasaki disease is an acute systemic vasculitis, a leading cause of acquired heart disease in children. It is increasingly being reported from India and other countries as well. Detection of coronary artery aneurysm at diagnosis is crucial for treatment intensification and to reduce morbidity and mortality. So objective of our study is to note the number of coronary artery aneurysm at diagnosis of KD, note the frequency of aneurysm in different coronaries, and to note the number of small, medium, and giant aneurysm in different coronary arteries. So it is a retrospective observational study conducted in Institute of Child Health, Kolkata, over a period of 4 years from January 2020 to July 2024. Children less than 18 years and diagnosed as KD as per AHA 2017 guidelines were included in the study. Aneurysm was detected by using ECHO, Dallaire et al. System we used, and score more than equal to 2.5 was taken as aneurysm. Patient with congenital heart disease and those who received treatment for KD prior to admission as excluded from the study. So among the 130 total KD patient included in the study, 51 had coronary artery lesion at diagnosis. 2 had only dilatation, 49 had aneurysm. So in our study, we got almost 38% has coronary artery aneurysm at diagnosis, among whom 23 had single aneurysm and 53% patient has multiple aneurysm at diagnosis. Gender distribution, male to female ratio was 2.7:1. Median interval from the onset of fever to the detection of aneurysm was 9 days, and median age at diagnosis of aneurysm was 14 months. Among the 49 patients with aneurysm, 25 was complete KD and 24 was incomplete KD. Number of aneurysm, total number of aneurysm noted among these 49 patients was 101, because many patients has multiple aneurysm. Distribution of these 101 aneurysm into different coronaries. LAD has the maximum aneurysm, 44, followed by LMCA, which has 29 aneurysm, and RCA has 28 aneurysm. Circumflex artery did not have any aneurysm in our study. The distribution of aneurysm according to size, there are total 76 small aneurysm, 23 medium, and 2 giant aneurysm in our cohort. And LAD being the leading artery in both small and medium, followed by LMC, RCA. The both giant aneurysm occurred in LAD only. So to conclude, about 38% children with Kawasaki disease had aneurysm at diagnosis. Male has significantly more aneurysm than female. More than half of the aneurysm, that is up to 53.06%, had multiple aneurysm at diagnosis. Among the coronary artery aneurysm patient, number of complete KD and IKT was comparable, almost the same. Aneurysm were more common in LAD, followed by LMC and RCA, and giant aneurysm was detected only in LAD. So this is my institute where I belongs to. I am sincere thanks to my whole pediatric department of my institute. Thank you all.
Is there any reason why the incidence of coronary artery lesion same classical and incomplete?
Sir, median duration, median age was 9 months. Almost all were infant. That can be one reason. Complete KD, maybe the detection rate is better. We are detecting aneurysm in the complete KD. The patient are not missed.
Your patients are classical and incomplete. You have already made that.
Yes, yes, sir.
Why the incidence is almost same?
More aneurysm are getting, nowadays we are getting more aneurysms. And that duration is also during the COVID time. So there are lots of patients are coming with multiple aneurysm as well.
Resection of the aneurysm after giving IVIG or before giving IVIG?
No, sir, these were at presentation.
Because the standard, the publication says that after the IVIG, incidence is less, and without IVIG, around 24 to 26%.
Yes, sir.
Your case that 8%.
Yes, sir. That was at presentation before giving IVIG. Actually, we did not wait for the echo. We gave IVIG. The first echo showed that. Preferably it was done within 24 to 48 hours of the diagnosis.
That means all your patients developed aneurysm within 3-4 days, which is actually not very common.
Yes, sir. We have 130 total patients.
No. I'm not asking on the number. But you are saying that majority of our patients 3-5 days, 6 to 7 days. Classically, aneurysm doesn't occur in that period.
Yes, sir.
Then how do you explain that?
Also the cases, I think it's all referred cases.
Yes, sir. Most are small aneurysm, but definitely there are increased number of median and giant also. Though the median age of detection was 9 days.
Thank you.
Request Dr. Riya Singh to come on the dais for the next presentation. Good afternoon, one and all. I am Dr. Riya Singh and I will be presenting my case series on coronary thrombosis in Kawasaki disease, a comparative data pre and post COVID period. Coronary thrombosis is a well-described complication in Kawasaki disease, usually in giant coronary aneurysm after 2 weeks of disease onset. This case series of 7 patients over 17 years with multiple coronary artery aneurysm and thrombus aims to compare
the pattern of coronary thrombosis before and following the pandemic. So we have 7 cases, 2 were pre-COVID and 5 were post-COVID. The first case was 10-month infant diagnosed with complete Kawasaki disease, developing thrombus on 18th day of illness with giant coronary artery aneurysm in all 3 arteries. Treatment was given, but unfortunately we lost the child during thrombolysis. The second case was 1.5-month infant presented with KD shock syndrome, developing thrombus on 14th day of illness with giant aneurysm in LAD and clot in LAD. Treatment was given and there was regression of thrombus and coronary artery aneurysms by 2 years follow-up. The next case was post-COVID. It was a 3-month-old infant with complete Kawasaki disease, developing thrombus on 26th day of illness with echocardiography showing medium coronary artery aneurysm in LMCA and LAD. The treatment was given and persistent coronary artery aneurysm was there with resolution of clot at 6 weeks of follow-up. The second case post-COVID was a 2-month-old infant with incomplete Kawasaki disease developing thrombus on 15th day of illness with giant coronary artery aneurysm in all 3 arteries. The treatment was given, here the treatment was given with streptokinase, clopidogrel and warfarin as well, and there was persistent coronary artery aneurysm in all arteries but no clot at 18 months of follow-up. The third case post-COVID was a 9-month infant with incomplete Kawasaki disease and the thrombus here developed on 5th day of illness with giant coronary artery aneurysm in LMC and LAD. Treatment was given and the thrombus resolved but aneurysms persisted. The fourth case after COVID was 6-year child with incomplete Kawasaki disease developing thrombus on 9th day of illness with giant coronary artery aneurysm in LMC and LAD. After treatment, the thrombus resolved but aneurysms persisted. The last case was a 9-month infant with incomplete Kawasaki disease developing thrombus on 11th day of illness with giant coronary artery aneurysm in LMC and LAD. After treatment, the thrombus resolved within 20 days of illness but aneurysms persisted. This image is of case 4 with giant aneurysm in left main coronary and left artery, anterior descending artery with marked increase in perivascular echogenicity. So our observation was that following the pandemic, we have observed an increased incidence of thrombosis, and post-pandemic, almost 4 out of 5 patients had earlier onset within 2 weeks that sometimes progressed in spite of the therapy. Post-COVID, there has been an increase in reports of vasculopathy and vasculitis. Although this was a very small study, but can we speculate this evidently increased incidence of thrombosis to be part of same spectrum? Thank you.
What is the reason?
Sir, we exactly don't know the reason, but it could be because of the COVID virus itself, or I feel there is more awareness and more detection of the cases now as compared to the 5-10 years back. So,
Any of your patients have COVID positivity?
no sir, we have not.
How can say?
Sorry sir?
And how can say that is still COVID?
Sir, it's just our observation post-pandemic, what we are seeing in patients, but we have not tested.
Anything happening after the epidemic will be post.
Yes, sir.
Epidemic itself has caused damage or itself is a responsible factor in COVID.
So, no, sir, we have not done that.
Antibody titering done, no? So then you get some idea, even though the first sender paper will be having sometimes RT-PCR positive or negative. And about the parameters are not mentioned actually, about the platelet situation and other variation. Okay.
Sir, actually it was a retrospective study, so all this was not done initially, and this is just our observation after all the cases have been there.
You observe the thrombosis part.
Yes, sir. Thank you, sir.
I request the presenter to quite KTK because we have to be marking.
Next, we have Dr. Sumti Verma.
Next to laser.
Good afternoon to all present. I'm sorry. Should I start, sir? Yeah. Good afternoon to all present. So, our study is on clinical profile and outcome of Kawasaki disease. It's a single center experience from a tertiary care referral center of Punjab, North India, that is DMC Ludhiana. As we know that Kawasaki disease is an acute febrile illness of childhood that is seen in worldwide in all populations, but now we see that it's more in Asian background as well. KD is a vasculitis that with a predilection of the coronary arteries. And approximately 20 to 25% of untreated patients experience coronary artery abnormalities, that is aneurysms. It's the leading cause of acquired heart disease in children in most developed countries, especially USA and Japan. In the last decade, more and more cases are being reported from different parts of India, but a large number of cases are still being missed due to ignorance among physicians about this disease. So that's why we conducted a retrospective study of cohort of 50 patients with Kawasaki disease over 5 years that was conducted in our department. Data was retrieved from medical records of patients admitted with KD collected from 2020 to 2024 and it was statistically analyzed. The results showed, first I'll present the demographic data. Our common age group was 1 to 5 and we had more male preponderance. The fever was present in all 100% cases with rash as the second most common symptom, followed by conjunctival changes and extremity changes. Then type of aneurysm, most commonly we saw a small aneurysm followed by medium aneurysm and then dilatation, which was calculated as per the Z-score. Then we did the correlation with coronary involvement, different correlations like the age group, there was no significant correlation found. Between age group and gender and coronary abnormality. With grade of fever also no a significant p-value was found, but with duration of fever we could see a significant correlation which showed that less than 7 days was significant if more coronary abnormalities was found. And then we did a subgroup division as well, where it was found that less than 14 days there was more coronary abnormality that was found. Less coronary abnormality was found in less than 14 days, more than 14 days more, and with a significant p-value. There were no significant changes with oral changes and rash, and no significant correlation with lymphadenopathy as well as extremity changes, and no significant with conjunctival changes as well. So we did a follow-up also. The follow-up was done in 72% of cases. And out of those follow-up, we found that 10 patients had aneurysm. All patients who had aneurysm earlier, 33 patients out of 50 had aneurysm. Then all those were followed up. Only 10 had aneurysm where size decreased. So cardiovascular manifestations can be prominent in the acute phase of illness and are the leading causes of morbidity and mortality. They develop in 20 to 25% patients with untreated KD. And it is associated with a mortality rate of 1 to 2%. It was associated in pre-IVIG area, which decreased to 0.08%. Deaths are most common 2 to 12 weeks after the onset of illness and are usually secondary to coronary aneurysms. So in our study, we found that fever, rash and non-exudative conjunctivitis were the most common clinical features. Rash was seen in 64% cases, where we saw with the other series. It was less because probably our cases reported late. Parents were not aware of rash, they were kind of fleeting rash and had atypical presentations. IVIG and aspirin was given in all our patients. In this case series, we found that duration of fever had most significant correlation with the coronary abnormalities, and 30.3% had aneurysm on follow-up, but all aneurysms reduced in size, and there was no mortality found in our study. So our conclusion is that this disease needs to be considered as a differential diagnosis in an acute febrile illness in children persisting up to 5 days. Fever more than 7 days, especially after 14 days, is significantly correlated with coronary abnormalities, and hence early diagnosis is important to prevent morbidity as well as mortality. Thank you. So that this should be considered as a differential diagnosis, and if it is missed early, we miss it, then as we have already seen here, that the long-term morbidity is very bad and we have sudden cardiac deaths, which is unexplained. So this has to be more and more, there should be a more and more knowledge about this, and it should be considered as a differential diagnosis if fever is persisting more than 5 days and we are not finding any significant cause.
What is the reason of all your aneurysm disappear?
They all did.
You said all your patients are late.
Sorry, sir?
You said all your patients arrive late. You said receive treatment late. Still all your patients improve.
Sir,
as far as the aneurysm is concerned, is there any reason?
Sir, the only reason of the rash was probably they reported late. So the percentage of rash is less, but the patients who received IVIG and aspirin, we saw on the follow-up that the size of the aneurysm reduced, and the aneurysm, the children who had small aneurysm and dilation, their aneurysm disappeared. It was the only reason of the late reporting was mentioned as rash, but otherwise they all improved on follow-up.
Institutional evaluation also is very important thing to compare with the data of the
Yes.
publications. And most of them are correlating, and take home message, I found that the fever more than 7 days was well correlated with
Yes, sir.
coronary artery involvement.
Coronary artery involvement. Yes, sir. Sir, and I want to mention one thing. Our echocardiographer is the constant person. He only did the previous, and because he's the one who has the maximum experience with this. So the echocardiographer was common in pre and post follow-up. Yes. Thank you, sir.
नेक्स्ट कौन है कौन सा ये वाला जजेस ओके करेंगे उसके बाद
Good afternoon once again. I'll be presenting our study on outcome of Kawasaki disease patients treated with corticosteroids and IVIG. Use of steroids in the treatment of acute Kawasaki disease was described by Dr. Tomisaku Kawasaki. RACE, that is randomized controlled trial to assess immunoglobulin plus steroid efficacy for Kawasaki disease study based on Kobayashi score to predict IVIG resistance, revived interest in the use of steroids. The aim of our study was to evaluate the response in patients treated with steroids in addition to IVIG and low-dose aspirin. Material and method was, it was a retrospective observational study from January 2020 to October 2024 in Institute of Child Health, Kolkata. Children diagnosed with Kawasaki disease as per AHA 2017 guidelines were treated with IVIG, low-dose aspirin, and patients with any of the following features received additional oral prednisolone and were enrolled in this study. Patients having Kobayashi score more than 5, patients with IVIG resistance and persistently high inflammatory marker 36 hours following IVIG, presence of myocarditis, dilated coronary arteries and small coronary artery aneurysms. KD patients with coronary artery Z score more than or equal to 5 and treated with infliximab prior to the corticosteroids were excluded from the study. The results were as follows. 145 children were diagnosed with KD during the study period, of which 51 received corticosteroids. Median age of recipients was 17 months and there were 31 males and 20 females. Median time for IVIG administration was 8 days. The median time for corticosteroid initiation was 10 days from the onset of fever. 29 patients out of 51 received steroids for small aneurysm, 8 out of 51 for dilated coronaries, 2 out of 51 for presence of myocarditis. 7 out of 51 patients received corticosteroids for Kobayashi score more than 5, of which 4 continued to have fever and later received infliximab. 5 out of 51 received steroids for persistently high CRP following IVIG along with clinical signs of ongoing inflammation such as oral mucositis. Of the 29 patients who received corticosteroids for small coronary artery aneurysm, 7 progressively increased to medium and rest 22 small coronary artery aneurysms and all dilated coronaries regressed after a median duration of 21 days. The limitation of our study was it was a single-arm retrospective study with small sample size. So we conclude that corticosteroids can be used for the treatment intensification in KD patients with dilated coronaries. However, 57% patients who received steroid based on Kobayashi scoring needed therapy augmentation and 24% patients with small coronary artery aneurysms progressed to medium size. Thank you.
All patients received IVIG?
Yes, sir.
Either blood received only 27%.
Sorry, sir.
How many patients received either blood alone?
No one received alone, sir. Every patient received IVIG and these were added, steroid was added based on Kobayashi score mostly.
From what are the points you have mentioned, any more limitations you think is there?
I can't think of anything, sir.
Your number was small.
Yes, sir.
And you stratify your patients, so much, right? So much very difficult to analyze the result.
Okay.
That's a weak point of this study.
Okay, sir.
Question is, and you have given steroid at different times.
Post IVIG, sir. On like yes, the
8 days sometimes 10 weeks, 10 days.
Yes, sir.
Some on what time of 2 weeks, someone received at the beginning of the therapy.
Yes, sir.
There is a wide variation in small size of cohort.
Yes, sir.
Okay, thank you.
Thank you, sir.
नेक्स्ट लेजर है
Good afternoon, everyone. I, Dr. Rosie Bhardwaj, JR at Dr. RPGMC Danda. I am presenting a study of comparison of the clinical profile of Kawasaki disease in below and above 6 months of age. Firstly, the background. Kawasaki disease is an acute inflammatory condition that primarily affects children under the age of 5 years. Younger than 6 months often present with atypical or subtle signs which can make diagnosis more challenging. The typical features such as rash, conjunctival injection, or oral changes may not be as pronounced. Fever in infants under 6 months may be the only obvious symptom, which makes it harder to differentiate from other febrile illness. Since infants below 6 months often lack the typical finding of KD, thus they are more likely to be misdiagnosed or diagnosed later in the disease course. Delayed diagnosis is linked to higher rate of coronary artery abnormalities. Study objective. This study analyzed the differences in the clinico-demographic and lab profile of Kawasaki disease in patients below and above 6 months of age. The study is a retrospective study analyzing the case records of KD patients at Dr. RPGMC Tanda. The patients were grouped into two, Group A and Group B. In Group A, the patients were below 6 months of age, and Group B includes the patient above 6 months of age. This study compares the clinical symptoms, laboratory markers, and cardiac findings. First, the demographic details. In Group A, which includes infants less than 6 months, in this, the male to female ratio was 6:1, and Group B, which includes children more than 6 months of age, the male to female ratio was 2.5:1. The mean age at diagnosis was 5 months in Group A and 45, that is 3.7 years in Group B. In Group A, all the patients were of incomplete Kawasaki disease, and Group B, 57 of incomplete and 43 of complete Kawasaki. Comparing the clinical symptoms, in Group A, which less than 6 months of age, the fever duration was 9 days. The mean duration in Group B was 7. The rash, which was 52% in Group A, and in Group B, that the mucocutaneous symptoms were more as compared to Group A. Comparing the laboratory parameters, in Group A, that is less than 6 months of age, there were seen thrombocytosis, ESR was raised, and coronary artery abnormality was seen in 57%, and in Group B, only in 15% were seen. The key results, the total cases which were taken was 53, diagnosed with KD. Mean age at diagnosis was 3.2 years, and the fever duration was 9.5 days in Group A and 7 days in Group B. The classic mucocutaneous signs were less frequent in Group A. The CA incidence was 57% in Group A and versus 15% in Group B. Conclusion, the KD in infant under 6 months is harder to diagnose due to incomplete symptoms. They have a higher risk of prolonged fever and coronary artery abnormality requiring early intervention. Early suspicion and diagnosis are essential to reduce the cardiac complications. Timely management is crucial, especially in developing countries like India. Recommendation, we can have early suspicion and vigilance. There can be prompt diagnostic evaluation, and we can enhance focus on laboratory markers and use of echocardiography in younger patients presenting with prolonged fevers, and awareness and education for the healthcare providers. Thank you.
Coronary ones are more common below 6 months of age.
Yes, sir.
So in such case, we give any patient?
Yes, sir. We give IVIG, methylpin, and infliximab in patients.
And you give steroid and infliximab?
Sir, yes, sir. Sir, when we detected the coronary artery abnormalities, aneurysms on echocardiography. Sir, after the diagnosis of Kawasaki disease. Sir, with IVIG. Yes. Sir, intranimethylprednisolone, the pulse therapy was given.
Only pulse?
Sir, pulse therapy with IVIG.
Pulse steroid, only pulse, single dose pulse?
Yes, sir.
And which, what's the dose?
Sir, 30 mg per kg per day.
Single dose?
Yes, sir.
Okay, thank you.
Thanks.
यही है ना? बिजी हैं जजेस। थैंक यू। ये पॉइंटर हाँ।
How many cases, how many times you are going to present?
Sir, this is the last. I have 2 cases, sir. Should I start, sir? Good afternoon, sir. My presentation is Kawasaki disease presenting with pneumonia, a diagnostic dilemma. So we know that Kawasaki disease is a medium vessel multi-system vasculitis that predominantly affects children younger than 5-year-old. If left untreated, about 25% of the patient develop coronary artery aneurysm. Diagnosis of KD is based predominantly on clinical features supported by some laboratory investigation. Infant can have incomplete KD. About 41% of the incomplete KD has been reported in India. And about 15 to 20% of the patient can have atypical features, making the diagnosis even more challenging. These are the references. So my first case is a 1.5-year-old male who presented with high-grade intermittent fever for 5 days with cough and cold and mild redness of lips and tongue for 4 days. And he had breathing difficulty and lethargy for a few hours before admission. There was no history of conjunctivitis, loose stool rash, or swelling of the hands and feet. On admission, that is on the day 5 of fever, child was sleepy and tachycardia, tachypnea was there, child was febrile, saturation was 88% in room air, and there was subcostal intercostal retraction and fine crepitations on auscultation. Hemoglobin was 8.8 and CRP was very high, 222 to 5 milligram per liter. Urine analysis shows sterile pyuria. So initial X-ray showed bilateral patchy opacities. Child was started on 2 broad spectrum. Child was already on 2 broad spectrum antibiotic and nasal cannula oxygenation 2 liter per minute. On day 8 of illness, that is 72 hours after starting antibiotic, child became afebrile, sensorium improved but became very irritable, and mucositis and tachypnea persisted, and oxygen requirements was almost same. CRP became 52, blood culture by that time came, it was sterile. So this is the repeat X-ray which showed worsening 72 hours after starting antibiotic. So on day 9 of illness, next day, child developed these features, sheet-like peeling from the feet and the periangular discommission. And perianal redness was also there and child was very irritable. Repeat investigation showed increasing platelet and ESR was 142. So a diagnosis of incomplete Kawasaki disease was made. Child was started on intravenous immunoglobulin 2 gram per kg over 10 hours and aspirin 5 milligram per kg per day. Antibiotics were stopped at this point. Echocardiography initial was normal. 48 hours after completion of the IVIG infusion, there was no irritability, child was maintaining saturation at room air, there was no distress, platelet showing increasing trend, CRP became 7.2 milligram per liter and X-ray showed remarkable improvement. And follow-up required 4 weeks was also normal. My second case is a 2-month-old female child who presented with fever for 6 days and cough and cold for 5 days and greenish loose stool with perianal excoriation for the same duration. Child had respiratory distress 1 day prior to admission, developed. Initial X-ray was right-sided, suggestive of right-sided lobar pneumonia. Child was already on 2 broad-spectrum antibiotics and nebulization therapy. At admission, child was anemic with a hemoglobin of 7.1, CRP and ESR was high. So, on admission, that is on day 8 of illness at our center, that is 48 hours after IV antibiotics, child was having fever with saturation of 87% at room air, subcostal intercostal retraction and bilateral crepitations. So, child needed PICU admission and nasal cannula oxygen and needed a 1 unit of PRBC transfusion also as hemoglobin was 7.1. Antibiotics were upgraded at this point because already 48 hours of antibiotic was done and child stress show worsening. Oseltamivir was also added empirically. Lumbar puncture was done as a workup of the fever and CSF study was normal. By that evening, child developed this rash, these macular rashes on the back mainly. So investigation was repeated on the same day, which showed increasing trend of the platelet. It became 10 lakhs and CRP became 192. When asked, mother gave a history of redness of the left eye without discharge, initial 2 days of illness and swelling of the feet for 1 day on day 4 of illness. The same day we noted this crusting at BCG site, so a diagnosis of complete Kawasaki disease was made. Child was treated with IVIG and low-dose aspirin. Antibiotics were stopped at this point. After 48 hours of completion of IVIG, X-ray showed marked improvement. There was no oxygen requirement, no irritability. CRP was showing decreasing trend. So below one was the previous, sorry. Very sorry. So lower down one was the previous X-ray, and that is the 48 hours after IVIG infusion. Echography, cardiography initial and through 8 weeks was, 6 weeks was normal. So highlight of the cases, both were infant, presented with features of pneumonia and treated with multiple antibiotics before diagnosis of KD. They did not respond to broad spectrum antibiotics. Features of KD developed subsequently in the first case, and there are some features in the history when we asked in the second case. So Monedero et al. Showed that chest radiograph finding in patients with KD are uncommon, about 20% in acute phase. Singh et al. Showed that only 1.83% of the children diagnosed with KD had predominant pulmonary presentation. Another study, Lee et al. Reported 15% of the KD patient with concurrent pneumonia. So the question remained, pneumonia in the presentation of KD, a syndrome or a sequelae of the two diseases. But to conclude, KD may mimic pneumonia, hence it should be suspected in pneumonia unresponsive to broad spectrum antibiotics. So careful history and monitoring of the patient is very important, as clinical features of KD can be transient or evolving. Thank you, sir.
The lung is involved, any organ can be involved in KD.
Yes, sir, it's a systemic vascular.
X-ray also included, and these consolidations say that. So it's good to know sometimes in the era of the SARS-CoV-2, lungs are more involved also.
Okay.
You could have done antibody to SARS-CoV-2 also in this case. You know the triggering agent. Infectious agent causing KD.
But they were, one is 2 months old, one is 8 months old. They both were infant. They born after COVID. After COVID.
It's a take-home message.
So the take-home message is KD can have varied presentation. It is a multi-system vasculitis. So pneumonia can be a presenting features. So before hiking up the antibiotics, we should look for the other features. We should even ask the mother regarding the features of KD which may have appeared previously. At admission, we may not find all features. And before hiking up antibiotic, we should exclude KD definitely. We should think of it. We should vigilantly look for that. Thank you, sir.
We have Dr. Sujit John.
Next, this judges के बोलने के बाद.
Shall I start, sir? A very good afternoon, everyone. My name is Dr. Sujit Matthew John, Junior Resident Pediatrics from PGIMH Chandigarh. I will be presenting an interesting case entitled A Silent Storm, Missed Kawasaki Disease in an Infant, presenting with giant coronary aneurysms, myocarditis, and peripheral gangrene. As we have heard multiple times already, Kawasaki disease is a medial vessel vasculitis, predominantly of children younger than 5 years of age, and it is currently the most common cause of acquired heart disease in children. Atypical or incomplete presentations of KD are more common among infants. Symptoms may often be transient, thereby precluding a prompt diagnosis and treatment. Even despite appropriate treatment, infants less than 6 months of age are more common to develop coronary artery abnormalities. Here I present a 3-month-old girl child from the Tri-City who presented with an acute febrile illness following her routine 6-week vaccination. Following this, she developed a generalized maculopapular rash which started over the trunk and progressed to the extremities. It was also associated with a non-purulent conjunctival injection and lip and oral mucosal changes in the form of redness, cracking of the lips and oozing of blood, and redness and strawberry tongue. For these complaints, she was taken to a local practitioner where she was treated with oral third-generation cephalosporins. Her fever subsided within 4 days and her other complaints resolved within 7 days. However, following this, the mother noted that she had skin peeling predominantly over the distal extremities. She remained well for a duration of 3 weeks following this illness. However, after this, she developed a new, well-defined erythematous facial rash and gangrenous changes involving the toes. When she presented to our pediatric emergency at this point, she was noted to be irritable and she was tachycardic. She had a new, well-defined rash over the malar regions. As we can see in this image, erythema had subsided following administration of intravenous immunoglobulin. She was also noted to have gangrene involving the first and second toes of both feet, and skin peeling of the distal extremities was also noted, as shown in this image. Laboratory investigations and admission revealed a normocytic normochromic anemia, leukocytosis, thrombocytosis, ESR of 26, a raised CRP, and a highly elevated pro-BNP level of 50,611. Coronary artery imaging was done at admission. A 2D echocardiography done at admission revealed a giant aneurysm with a Z-score of plus 15.04 involving the left anterior descending, and medium-sized aneurysms involving the LMCA and the right coronary artery. During the course of our admission, a CT coronary angiography was done, as shown in this image. Here we see a complex coronary aneurysm involving the left main bifurcation with extension into the osteoproximal LAD and the left circumflex, as seen here. We also see two distinct aneurysms involving the mid-LAD, which was again a giant aneurysm, and another aneurysm involving the proximal right coronary artery. Given a diagnosis of Kawasaki disease, she was given intravenous immunoglobulin at 2 gram per kg on day 1 of admission. Immunosuppression was intensified with pulse methylprednisolone, which was given at 30 mg per kg per day for 3 days, followed by prednisolone at 2 mg per kg per day. She was also given cyclosporin and infliximab at 10 mg per kg. In view of bilateral lower limb gangrene and giant coronary aneurysms, she was given therapeutic dose anticoagulation with low molecular weight heparin, and she was given antiplatelet doses of aspirin. However, during the course of her admission, she developed hemodynamic instability in the form of lethargy, poor peripheral pulses, and prolonged capillary refill times. She was managed with intensive care measures involving an IV fluid bolus, vasopressor, and inotrope infusions, and she required non-invasive ventilatory support. With these measures, she gradually improved. She was given a second dose of intravenous immunoglobulin, 1 gram per kg in view of myocarditis, and prior to discharge, she was started on beta blocker and atorvastatin. She was discharged in a stable condition on tapering doses of prednisolone, cyclosporin, aspirin, therapeutic doses of LMWH, propranolol, and atorvastatin. She came for review last week, and a follow-up echo revealed that she had persistence of the aneurysms with some interval decrease in size of all 3 aneurysms. My message from this case is that prompt recognition and timely treatment of KD are crucial to prevent the devastating complications of KD, as we see in this case. And a high degree of suspicion is required to make the diagnosis, especially with incomplete or atypical presentations in infants. Thank you.
Yeah, definitely your case report was a learning lesson for everyone, especially personally with the runners of the time and they started with the early antibiotic. It is very important thing. For your information, when you show the face of any child, the eye should be black out. The palm has to be has got the legal issues. And there is an important thing, early diagnosis is important.
At what point of time the patient got admitted?
So this was on day 28 of illness, sir.
Now you have given steroid to this patient.
Yes, sir.
How did it help you?
Sir?
How did it help you?
Sir, initially when she presented to us, she was hemodynamically stable, but later she developed instability also. And yes, sir. Yes, sir.
You have given steroid at 20 days.
Yes, sir. Yes, sir. Sir, but when she presented to us, she was noted to have active myocarditis. She had ST depressions involving all 6 anterior leads, and she had troponin T elevated. So we noted that she had active myocarditis, and she probably had signs. She had giant coronary aneurysms to us. So we realized that she was an active disease. Her CRPs were elevated, ESROs were elevated, and she was lethargic also, sir.
Thank you.
Next, laser.
A very good afternoon, everyone. I am Dr. Tanya Singla, Senior Resident in the Department of Pediatrics, AIIMS Delhi. So I would be presenting two cases today on coronary abnormalities beyond Kawasaki disease. So coming to the case one was a 2-year-old girl who presented with features of fever for 4 months and intermittent abdominal pain for the last 3 months. On examination, she had stage 1 hypertension, pallor, and hepatosplenomegaly. Rest of the systemic examination was normal. Coming to the course before presenting to us, child was already managed with multiple oral and IV antibiotics, and she had anemia, neutrophilic leukocytosis, thrombocytosis, and raised inflammatory markers. Before presenting to us, she already had an echo which had shown coronary dilatation, and already she had received 1 dose of IVIG at 2 gram per kg, oral steroids, and aspirin. On presentation to us, she had persistent fever and abdominal pain. So, echo done at our center had revealed coronary dilatations with RCA and LED showing moderate dilatations and LMCA showing mild dilatation. So, in view of stage 1 hypertension and persistent pain abdomen, we went ahead with CCT abdomen, which had shown multiple splenic and renal infarcts. And we did a DSA also, which had shown multiple bilateral renal artery aneurysms. So our diagnosis was revised to PEM, and we gave her IV methylprednisolone pulse for 3 days followed by oral steroids, and IV cyclophosphamide was given as monthly doses for 6 doses followed by MMF. We followed her regularly with echocardiography, and her echo had normalized by 4 to 5 months post-treatment. Coming to case 2, we had a 3.5-year-old boy with chief complaints of fever for 1 month, maculopapular rash over trunk, non-exudative conjunctivitis, cheilitis, and abdominal pain. And 2D echocardiography had revealed giant coronary aneurysms involving LCX and LMCA, and mild dilatation of LAD and RCA. On further evaluation, child also had myocardial involvement. So a diagnosis of Kawasaki disease was made, and he was given aspirin and IVIG, following which the symptoms had resolved. But 15 days later, he again presented with fever, rash, chest pain, abdominal pain, and there was persistent rise in inflammatory markers, and echo had shown a rise in coronary sizes, and cardiac CT with angiography had shown diffuse fusiform dilatation of LMCA, proximal and mid LAD, and proximal LCX with ectatic changes in RCA. So child was given, thinking that it was a refractory Kawasaki disease, he was given infliximab along with steroids, aspirin, low molecular weight heparin followed by warfarin, and following which symptoms were resolved and he was discharged. But 2 months later, he again presented with fever, blood in stools, and abdominal pain, and with persistently high CRP and ESR. Upper GI endoscopy had revealed pseudoaneurysms, and so we did DSA, which had shown stenosis and bleeding in celiac trunk branches and aneurysm in the segmental renal arteries. So, final diagnosis of PAN was made, and he was given IV cyclophosphamide pulses followed by MMF. So considering that this was a medium vessel vasculitis with multi-system involvement and relapsing course on steroid tapering with characteristic DSA findings, we manage him as PAM. So the learning points from both of my cases are that not all acquired pediatric coronary disease are Kawasaki disease, and a high index of suspicion should be kept in cases not responding to IVIG steroids, especially having prolonged courses. And coronary involvement in most cases is mostly reported with Kawasaki disease, but PAN being a systemic vasculitis can also have coronary involvement, and distinction between both of them is necessary as they both have different therapeutic and prognostic implications. Thank you.
In your second case, after 15 days again showed the rashes, fever. That was a readmission or the same sub-acute?
So that was a readmission. That was a readmission, sir.
Readmission.
Yes.
Say that you have to clinically differentiate between that. What is your suggestion? How will be differentiated? And KD.
So KD, as we all know, mostly has an acute onset and symptoms are mostly acute. But PAN being a systemic vasculitis mostly has a chronic and insidious course. Like in both the cases, they presented mostly after 1 to 2 months of having the symptoms. Also the age, though both of our cases were toddlers, but toddlers like KD is mostly seen in toddlers, while PAN is mostly seen in after 5 years of age. Though hypertension, coming to examination, hypertension is mostly seen with PAN, but it rarely occurs with KD if we have renal artery stenosis, which is rarely reported with KD, sir. And
did you examine for the hypertension in these 2 children?
yes, sir. Our first case had stage 1 hypertension.
That means you have not seen the pulses also.
Sir.
That's why we are stressing, examine the person from head to toe.
Yes.
Okay, thank you.
Thanks.
That's a good case.
Thank you, sir.
ऑडिटोरियम बंद कर देना.